Okay, so we know that long-standing HIV is associated with impaired bone architecture and pubertal delay. And puberty is a crucial period for peak bone mass accrual. And this is a determinant of adult bone mineral density and fracture risk. So a cohort study was conducted in Zimbabwe which compared bone density and muscle function in peripubertal children with HIV and those without HIV aged 8 to 16 years. And this study found a higher prevalence of size-adjusted low bone density in the children living with HIV. The prevalence of low bone density in children living with HIV was 10% compared to 6% in children without HIV. So as a result, we sought to investigate whether low dietary vitamin D and calcium intake were associated with low bone density at baseline in peripubertal adolescents living with HIV in Zambia and Zimbabwe. So I'm going to present the findings of a baseline analysis of a phase 3 dual-site randomized control trial taking place in Lusaka, Zambia and Harare, Zimbabwe, in 842 adolescents with perinatally acquired HIV, aged 11 to 19 years, who have been established on antiretroviral therapy treatment for at least 6 months. Our outcome of interest was DEXA-measured total bodiless head bone mineral density Z-score. So this is a recommended size-adjusted bone density measurement for children. So in total, we enrolled 842 participants across the 2 sites, and most of our participants were female. 20% of our study participants were virally non-suppressed, and 30% of our study participants were stunted. That is, they had a height for age Z-score of less than -2. And amongst those 30%, the majority of them were male participants. So we defined low dietary vitamin D intake as vitamin D consumption of less than 4 micrograms, and low calcium intake as calcium consumption of less than 150 milligrams. So this was based on a standardized dietary questionnaire that we administered to our study participants. And we found that 75% of our study participants had low calcium consumption, and 20% of our study participants had low vitamin D consumption. We also assessed Tanner stage, which is an assessment for development of secondary sexual characteristics in adolescents, and is usually divided into 5 stages, with stage 1 being an adolescent who has not developed any secondary sexual characteristics, and stage 5 being an adolescent who has fully developed their secondary sexual characteristics. And we noticed, and we found that more girls than boys had achieved Tanner stage 5. And with regards to bone density, a lot more boys had a lower bone density Z-score than girls. After adjusting for sex, Tanner stage, household wealth quintile, and country, we found that a 1 microgram decrease in dietary vitamin D intake was associated with a decrease in bone density of 0.06. And a 100 milligram decrease in dietary calcium intake was associated with a decrease in bone density of 0.1. So our study findings show that low bone density is associated with low dietary intake of vitamin D and calcium. And we think that adolescents living with HIV in Zambia and Zimbabwe may benefit from vitamin D and calcium supplementation to improve bone health. And this is why we are conducting our clinical trial called the Vitality Trial, which you can read about on our website. And please don't forget to sign up for our newsletter. You can also follow us on our Twitter page or drop us a line at the email address provided. I would like to thank and acknowledge the funder of this project, the EDCTP, our trial sponsor, the London School of Hygiene and Tropical Medicine, the Vitality participants, Vitality investigators, and clinic staff for making this trial possible. Thank you.